As presented previously, FDA has stated it does not intend to focus its oversight on health management functionality, including most clinical decision support, as it falls under such description. FDA, however, will focus its oversight on a limited set of some software functionalities that provide clinical decision support and pose higher risks to patients. The questions that mobile health and the broader health IT industry community is asking, therefore, are exactly what types of intended uses warrant regulatory oversight of clinical decision support software? And precisely when software informs the decision of a medical profession, where do we draw the line between software in support of the practice of medicine and software that the professional is so dependent on that it essentially replaces competent human intervention? And at last, if we assume that we have adopted the framework, or at least terminology, by the IMDRF and intend to expand it from just software as a medical device to all clinical decision support software, how do we assess the significance of the information provided, as well as the seriousness of the healthcare condition? An important step forward in answering these questions was made in December 2016, when the 21st Century Cures Act, also known as Cures Act, was signed into law by then-President Obama. The Cures Act has a host of provisions included to improve how the FDA reviews and approves drugs and medical devices, ranging from humanitarian device exemptions to institutional review board process for multi-center device trials. It also provides substantial funding for 3 signature Obama administration research programs over the following 10 years: the Cancer Moonshot, the Brain Initiative, and the Precision Medicine Initiative. Plus, it gives states funding to fight the opioid crisis and deliver an additional $500 million to the FDA. Among the numerous provisions of the Cures Act, the one of highest interest to us in this course is Section 3060, Clarifying Medical Software Regulation. This section modifies the definition of a medical device to remove a number of categories of software from FDA's jurisdiction. The categories of software removed from the device definition are software that provides administrative support of a healthcare facility, software for maintaining or encouraging a healthy lifestyle, and software that serves as only electronic patient records. And at last, software for transferring, storing, converting formats, or displaying data. In case you're not familiar with it, the Senate MedTech Act had passed out of the Senate Health Committee early in 2016. The name stands for Medical Electronic Data Technology Enhancement for Consumer Health Act, and it is one of Senator Hatch's bills advanced to ensure that regulation of low-risk technology do not hinder innovation. This consists in the position of the major industry association on regulating health IT, which calls for Congress to work with HHS to develop a risk-based oversight framework for such software or hardware that takes into account factors such as risks relative to intended use and cost benefits of any proposed oversight, with intent of ensuring patient safety. The MedTech Act and the Cures Act that includes it are significant pieces of legislation and especially important in the context of clinical decision support software. For context, the FDA had several years prior announced its intention to develop a guidance document explaining the types of clinical decision support software that it intends to regulate. However, a draft is still being awaited. The Act does not, of course, replace the need of a guidance, but it does bring light into especially one important concept, that if a physician has access to all of the underlying information such that the physician can double-check the basis for any recommendation, then the software is really simply supporting the physician's practice of medicine, and the FDA should not regulate. It's worth emphasizing that the Act, amended the medical device definition, which has happened very infrequently, generally only once every several years, since the medical device amendments of 1976. Let's now go through the 5 categories of software that since 2016 are excluded from the medical device definition. The first one is straightforward, and it is software that provides administrative support of a healthcare facility, including the processing and maintenance of financial records, claims or billing information, appointment schedules, business analytics, admissions, inventory management, laboratory workflow, and others. This was arguably never in question, as this category of software are obviously not medical devices, although the case for regulation was made at times in the past decade or so. The Act essentially removed the potential controversy once and for all. The second category of software removed from the definition is software for maintaining or encouraging a healthy lifestyle, and is unrelated to the diagnosis, cure, mitigation, prevention, or treatment of a disease. As you remember from the past module of this course, already in the General Wellness and Mobile Medical Applications Guide and documents that the FDA had said that even in these types of software fall within the definition of a medical device, FDA does not intend to regulate them as a matter of agency enforcement discretion. So the Act essentially has taken them off the table altogether. Category number 3 includes software that serves as electronic patient records, including patient-provided information, to the extent that such records are intended to transfer, store, convert formats, or display the equivalent of a paper medical chart, so long as such records were created, stored, transferred, or reviewed by healthcare professionals or by individuals working under supervision of such professionals. And also, the software is not intended to interpret or analyze patient records, including medical image data, for the purpose of diagnosis, cure, mitigation, prevention, or treatment of a disease or condition. As the previous one, this definition also codifies policy already implemented by FDA as a matter of enforcement discretion. The risks implied in this category are not too dissimilar from those of a medical device data system, which we have learned about in a previous module. The fourth exclusion provided in the Cures Act is software intended for transferring, storing, converting formats, or displaying clinical laboratory tests and other device data and results, findings by the healthcare professional with respect to such data and results, general information about such findings, and general background information about such laboratory tests and other device, unless the software is intended to interpret or analyze clinical laboratory tests or other device data, results, and findings. This category appears to include products meeting the definition of either a medical device data system or a laboratory information system. We have talked about medical device data systems and how FDA is exercising enforcement discretion not to regulate them. This provision again codifies that position. But regarding laboratory information systems, FDA had regulated them as 510(k) exempt Class 1 devices, hence enforcing quality system regulation for these devices. Under the exclusion, these products will now not be subject to regulatory requirements at all. Now, here comes the most interesting of the 5 categories. This is software displaying, analyzing, or printing medical information, further supporting or providing recommendations to a healthcare professional about prevention, diagnosis, or treatment, as long as it is also enabling such healthcare professional to independently review the basis for these recommendations. Well, this is the working definition of clinical decision support software. In lack of a clinical decision support guidance, The Act thus, in a way, resolves the status of software that uses big data and advanced computing capability to provide some clinical decision support to healthcare professionals by excluding the software from the definition of a medical device altogether. Despite the fact that the Cures Act signaled an important step forward in clarifying clinical decision software regulation, more clarity is wanted by industry. First, the application of the definition in the last category will not always be self-evident. What does it mean for a healthcare professional to independently review the basis for software recommendations? What is the sufficient level of transparency that allows a healthcare professional to discern the clinical basis of a recommendation? And what is the software amasses very large data sets from hospital records? What is the minimum level of competence expected by the physician so that he does not primarily rely on the software making diagnostic and treatment decisions? It seems at the minimum that there is an opportunity to further clarify criteria, such as transparency of the software and contextual factors related to its utilization, that enable the healthcare professional to independently review the recommendation that the software makes, such that he or she is not dependent on the software. Contextual factors may include user competence, but not only. For example, time for evaluation and determination might also be very important. Note that the definition of category number 5 of software does not include software where the function is intended to acquire, process, or analyze a medical image, or a signal from an in vitro diagnostic device, or a pattern, or a signal from a signal acquisition system. The definition actually starts with this exclusion, which makes it a little bit difficult to read. However, it's not surprising. Had this clause not been included, one could argue that computer-assisted detection or diagnostic devices that analyze image data, for example, identifying suspicious lesions in an MRI scans, and in vitro diagnostic devices are a type of clinical decision support. Yet, for decades, FDA has regulated software that analyzes medical images and certain signals from electronic medical devices, as well as software that processes signals from in vitro diagnostic devices. So this clause simply signifies that the agency intends to continue to do so. Of note, Section 3060 of the Cures Act has an escape hatch. If FDA believes that software of the types described would be reasonably likely to have serious adverse health consequences. To bring the software back into its jurisdiction, the agency must issue a final order in the Federal Register, providing its rationale based upon the potential for and severity of patient harm if the software does not perform as intended, the extent to which the software is intended to support the judgment of a healthcare professional, whether a healthcare professional has a reasonable opportunity to review the basis of the information or treatment recommendation, and finally, the intended user and use environment. It is quite an elaborate process, and I would be very surprised to see this mechanism used, but in very exceptional circumstances. It does speak, I believe, to a certain level of discomfort and diffidence still remaining around clinical decision support, which hopefully will lessen over time with safe and effective use in clinical care. If you're interested in staying on top of current regulatory challenges, clinical decision support software remains one to watch in the remaining of the year 2017 and beyond. I believe healthcare is one of the ripest areas for industry to disrupt using advanced algorithms and the data sets to train those algorithms, in that there are many data sets whose value is not yet recognized. If FDA continues to collaborate with other agencies and industry, as well as it has done in the past, We're bound to see a lot of innovation and progress in regulatory thinking in the next years.